Hey, good morning. I'm Vic Sinise. I'm the host of the Europatient podcast. Welcome to the show. We got a great show for you today, so join us now. I'm going to be your guide through a topic that can cause a great deal of anxiety for many men when you get that abnormal PSA result. So the title, What Comes Next, you may be surprised. It's a bit of a teaser. That's because the conventional wisdom around an elevated PSA has changed dramatically over the last decade. Thank goodness. My goal today is to demystify this process and show you that an abnormal PSA is not an automatic sentence for a biopsy or surgery. We'll explore the modern, more personalized path to a prostate health diagnosis. So let's start with the basics. What is PSA? Well, PSA stands for prostate-specific antigen. It's a protein that's produced by your prostate gland, and a small amount of it normally leaks into your bloodstream. So the PSA test is just a simple blood test that measures the level for this protein. For decades, it has been our primary tool for screening. While it's an excellent tool for indicating a potential problem, it's crucial to understand one key point. The PSA test is not a direct test for prostate cancer. So when you hear, I have an elevated PSA, it doesn't mean you have prostate cancer. It means you have an elevated PSA. I sometimes refer to it as the check engine light. It goes on. Sometimes there's a problem. Sometimes there's not. PSA. It's a measure of prostate health in general, and many things cause the PSA level to rise besides cancer. Now, when we talk about an abnormal PSA, we're simply referring to a level that is higher than what is considered typical and adjusted for your age. The problem is that this isn't a fixed threshold. A PSA of 4.0 was once considered the universal cutoff. Everybody who had a higher than a 4.0, they were probably going to get a biopsy. But now we know it's not that simple. Many factors can influence your PSA level. A simple urinary tract infection, vigorous exercise like cycling, especially the bike seats, a recent ejaculation, or even a rectal exam can temporarily raise your PSA. Now, age is another big one. PSA levels naturally tend to increase as a man gets older. So, an abnormal number is a signal to investigate, but not a definitive diagnosis. For years, the standard protocol was pretty straightforward. If your PSA was elevated, the next step was almost always a biopsy. Now, this procedure, which I was involved with for most of my career, involves using an ultrasound probe and a guide needle and taking several random tissue samples from different areas of the prostate. Now, when I first started out, we were taking only 4 samples. Then it went to 6 samples. Now 12 is pretty much the standard. I've seen 24 and more. So it's not a simple procedure as a patient goes. It's often referred to as a blind biopsy because the doctor is essentially taking samples from a grid hoping to hit a target they can't see. This approach has 2 significant problems. First, it's invasive. Trust me, as somebody who's done a bunch of these, it's invasive and carries a risk of infection and bleeding. Now, those risks are not zero, but they're not high. But, I always tell patients, if you're the one who has the bleeding or you get an infection, I don't care if the risk was 1%. It's 100% for you when you get it. So keep that in mind. Second, it's a bit of a shot in the dark. It can miss an aggressive, dangerous tumor. Or worse, it can find a small, slow-growing cancer that would probably never cause harm, leading to an unnecessary anxiety and treatment. Now, this is where the surprise comes in. We have moved beyond the old one-size-fits-all approach. Today, an elevated PSA is the starting point for a personalized risk assessment. Instead of immediately jumping to biopsy, the old way, we take a step back and use a range of new tools to gather more information. This modern approach is all about asking smarter questions and getting a clearer picture before making any decisions. The goal is to avoid unnecessary procedures while ensuring we don't miss dangerous cancers that need to be treated. We want to be able to distinguish a true threat from just a nuisance. So what are these new tools? Well, before we even think about imaging, we can get more out of the PSA itself. Two key metrics are PSA velocity and PSA density. So what are those? Well, velocity looks at the rate of change over time. So if you've been getting PSAs for a while, as many men do once a year, starting usually age 50, the numbers, and it's the number steadily climbing, or did it just have a one-time jump? Now, density looks at something else. Density looks at the PSA level in relation to the size of your prostate. So a large prostate may have a high PSA naturally. Kind of think of it as more prostate, more PSA, right? Makes sense. Whereas a high-rise PSA from a small prostate might be more concerning. We also now have sophisticated genetic and molecular tests, often done from a simple urine or blood sample, that can analyze something called biomarkers to assess your risk of having or developing aggressive prostate cancer. That's a big change, folks. Usually we were trying just to find out yes or no prostate cancer. Now we're looking for if somebody got a prostate cancer that could be aggressive enough to be a problem. Now this is one of the biggest game changers, prostate MRI. Prostate MRI is a sophisticated imaging test that gives us a highly detailed 3D map of the prostate gland. It can help us identify specific, suspicious areas that may cause for concern. This is think of it like this. Instead of a blind search, the MRI gives us a treasure map with an X marks the spot. This allows us to move from random, inefficient biopsy to targeting the precise area that you need to look at. So once a suspicious area is identified on MRI, the next step may be an MRI guided fusion biopsy. So we take the old ultrasound that we were using blindly and merge it with the MRI image that identified an area to be concerned about. Now this technology merges those detailed MRI image with a live ultrasound feed. So the doctor can see the suspicious spot from the MRI overlaid on real-time ultrasound image, allowing them to precisely guide the biopsy needle directly into the specific area. This is far more accurate method than the old random biopsy, significantly increasing the chance of finding a significant cancer. Hearing that word, we don't want to catch these cancers that are not going to be life-threatening, and reducing the chance of finding a low-risk insignificant one. Now let's say you had a biopsy and it's confirmed prostate cancer. This is where the biggest surprise often comes in. For many men, the next step is not treatment, it's observation. Now stop a second and think about that, because it seems weird for somebody to say, oh, you have cancer, but we're not going to do anything about it. Well, it's not exactly not doing anything about it. It's observation. This concept is called active surveillance, which means we're actively watching it. It's a carefully managed program where we monitor low-risk, non-aggressive cancers with regular PSA tests, physical exams, and even sometimes repeat biopsies. We only intervene with treatment if the cancer shows sign of progression. For many men, this means they can live a full life without ever needing surgery or radiation. And that avoids those side effects that come with these two treatments. This is a dramatic shift from the old mentality that all cancer must be removed immediately. Active surveillance is not for everyone. It's reserved for men with very specific criteria. They must have low risk, low volume cancer, and they must be healthy enough to undergo a full treatment later on if necessary. They also need to be comfortable with ongoing monitoring. Now this is where you guys come in, the patients. You know, when you're told you have cancer, everybody freaks out and says, get rid of it. I want that gone. Listen to the doctor. Listen to what they're telling you. Monitoring may be your best option. So don't jump at going into, big operation or radiation just because you're nervous about the diagnosis. I want to emphasize that this is not a passive wait and watch approach. It's an active, ongoing program with a specific schedule of follow-ups. It's a way to manage the cancer without over-treating it. Of course, for many men, treatment will be necessary. If a biopsy reveals an aggressive or high-risk cancer, or if a man does not fit the criteria for active surveillance, then the traditional treatments are used. These typically include surgery known as prostatectomy, or removal of the whole prostate, or various forms of radiation therapy. While these are significant procedures, the good news is they are highly effective and have excellent tools to manage side effects and help men return to a normal quality of life. So, to sum up the journey, this simple flowchart illustrates the shift. The old path was a straight line, high PSA, boom, biopsy, which leads to treatment. The new path, a more thoughtful winding road. An elevated PSA is just the beginning of a conversation. We use advanced metrics and imaging to guide a targeted biopsy. This all leads to personalized decision. Whether that's active surveillance or a curative treatment, this new process allows us to make smarter, more informed decisions for our patients. In closing, I want to leave you with these key takeaways. First, an abnormal PSA is not a cancer diagnosis. Second, a biopsy isn't an automatic next step anymore. And then, third, we now have amazing technology like MRI and fusion biopsies to get a more accurate picture. And finally, for many men, we now have a powerful option in active surveillance, which allows them to live a full life while avoiding unnecessary treatment. The new approach is all about personalized, smarter care tailored to the individual. Hope you enjoyed that episode. Tune in every week for more on the Europatient Podcast.